Okay, welcome everybody. Before we get started, I just wanted to give some information about how folks can obtain their continuing education contact hours from this webinar. So on the screen you'll see a link to the NYU Silver Continuing Education portal, and if you go there, you can log on to the Continuing Education online portal for NYU Silver School of Social Work, and then click All Events and Programs tab. And then when you scroll down, you'll be able to find today's webinar under online learning, and then you can register, fill in the billing information, click register, and pay the CE registration fee. I believe that's about $15. It goes to NYU. Just remember, our system works best with Google Chrome or Mozilla Firefox. And then once you get on there, after registering, you'll receive a confirmation email with a link to complete a brief evaluation. And then you'll have 24 to 48 hours to go back to your registrations, and then you will take a brief assessment, a brief knowledge test in red next to the name of the program. And then once you complete the assessment and you're done, you'll be directed on how to download your CE certificate. If you have any questions, there's a number there that you can call, 212-998-5973, or email silver.continuingeducation@nyu.edu, and they can give you more information on how to get your CEs. And we'll post this information once again at the end in case anybody misses it. So before starting with the webinar, I'd just like to give you a couple of technical issues, address a couple of technical issues. First off, if you come across any problems with the WebEx system, please chat to the host, and you can find the chat box on the right side of your screen. If it does not appear, click the dialog bubble on the top right toolbar, and it will pop up. And again, if you have any concerns, you can chat to the host. During the webinar, you can chat comments or questions to the panelists, and then we're going to compile those and hold the questions and comments until the end of the presentation. Okay, so thanks for joining us, and let's get started. Good afternoon, everyone. My name is Jim Rodriguez, and I'm a senior research scientist at McSilver Institute, and I'm also a state licensed clinical social worker and psychologist. And I have done research, training, and I have practice experience in many areas of mental health, but I have a particular interest in working with trauma and in trauma-informed care. Today's webinar, Resilience-Informed Service Environments, is going to focus on resilience. We'll talk a lot more about resilience in the context of trauma. I will be presenting today with Dr. Anthony Salerno, and I'd like to turn it over to Dr. Salerno, have him introduce himself, and get us started.
Hi, everybody. This is Tony Salerno. Maybe some of you have maybe met along my 30 years with the Office of Mental Health and 7 years here at the Institute, McSilver Institute at NYU. And so my background is I'm a psychologist as well, and I've spent 30 years working really with adults with serious mental illness in a variety of outpatient, inpatient programs, very involved with evidence-based practices. As well as the last 7 years, I've also been involved with the National Council for Behavioral Health. And there I've been involved in establishing national learning communities, really looking at the whole area of trauma-informed care. And so, over those years when I really delved into the whole area of understanding how adverse life events can contribute to the person's current physical issues, emotional difficulties, their risk around substance use, one of the areas that kept striking me was, gee, there's a heck of a lot of people who've gone through some very, very tough things, and yet they're not experiencing some of the negative or the most serious negative effects that many others have experienced. And that is an area that I think is extremely important. And Jim and I, in thinking about this and here at the Institute, thinking that, we really need to take a look at the other side of the coin, and that is the area of resilience, those protective factors and how we strengthen that. So I'm really excited about this whole topic area. I think it's an area that has been increasingly studied, but also now looking at, well, so what does it mean for the work that we do? So now that we know that there's such a thing as both risk as well as resilience, how can that contribute to improving the quality of services that we provide? And that's a big question. And we're so pleased that you've joined us so that we can begin to, collectively begin to perhaps answer some of those questions. We haven't got a pat solution or a pat answer for any of these things, but we think that it's an area that we need to expose ourselves to build awareness, to understand what we mean by resilience. What does the science have to tell us? Even though it, in many ways, is still in its infancy in certain areas, but very well established in others. So we're really looking forward very much to sharing this with you. Also, we're going to be asking you, for those of you who may not be able to stay on until the very end, this is one webinar. We will be very interested in knowing whether or not you have an interest in hearing more. Wanting to go perhaps a little bit more in-depth in various topics that we're just going to basically sort of, brush on in some ways today as an introductory webinar, or whether you really have an interest in going further, of really being interested in applying what you've learned in the work that you do. And here at McSilver, we are very interested in just responding to the felt need that you guys have out there. So we're going to be asking you that. So as you get an understanding of this whole approach, if you are interested in learning more, and we'd like to be able to be responsive to you in that regard. Yeah. Okay, Jim, I turn it over to you.
Great. Yeah, and as Tony said, I mean, we know this is a complex topic. We hope we're going to be able to give you some idea of how complex it is, but also how important it is to health and behavioral health providers. So this is our agenda for today. We're going to talk a little bit about understanding resilience, the concept of resilience on a deeper level. Oftentimes, there's misconceptions and actually there's controversies around resilience. We're going to discuss the neurobiology of resilience. There's a growing science looking at the neurobiological substrates of resilience and how it develops within the brain, and so we're going to touch on that. And then a lot of researchers are starting to look at resilience and developing interventions that focus specifically on building resilience, as opposed to sort of a traditional focus on, especially in mental health, on reducing symptoms, more on building resilience. So we're going to talk a little bit about that, and then we're going to talk about what we are learning now about the very specific kinds of things that you can engage in to build resilience with your clients. First, though, we'd like to start with a very simple poll question. We just want to know who's out there in the audience. So very quickly, if you could just give us a sense of who you are. We have a few choices here: adult mental health providers, child and adolescent mental health provider, adult care manager, a child and adolescent care manager. You'll see the choices there. If you could take a quick minute just to give us an idea of who you are, who's in the audience, just so that we have a sense of who we're talking to.
So we have to give you a moment to respond to the poll question. We also have our colleague Brianna, who is helping us with this. Brianna, is the poll question up?
It is up. It will generate responses in about 6 seconds so everyone can see what the results are.
Great. Thanks so much. And I really would love to just hear from everyone. Thank you, Brianna. Okay, so it looks like we have percentage, let's see, it doesn't give us, okay, we have a huge number of folks who are on, which we're very pleased about. We have like 23 adult mental health providers, 33 child adolescent providers, about 12 adult care managers, 14 child adolescent care managers, substance use providers, supervisors, 34 supervisors, and a large number of administrators, and then some about 40 most who somehow fall in other sorts of like roles. But anyway, so what we know now is that we have a very broad spectrum of folks who are on this, and we're actually very pleased with that. Thank you.
Yeah, because we think that the concept of resilience really applies in a lot of different service systems and across the developmental spectrum from childhood to adulthood to and adolescence and aging. So let's get into the material. As Tony mentioned already, we believe that understanding resilience is important. It's what we consider the other side of the coin from trauma. So So we know from the ACEs studies, and we've done a number of webinars on the impact of adverse childhood events on adult health and mental health outcomes and social outcomes, behavioral outcomes, substance use, and so on and so forth. And we've done a number of those. And one of the things that we've come to realize is that it's critically important to understand resilience. Resilience, in many ways, is the study of how we cope with stress and adversity, extreme stress and adversity. And so we understand trauma by understanding resilience, and vice versa. We understand resilience only by understanding trauma and how it operates. And so that's why we really feel it's critically important, especially in the context of working with trauma, to understand resilience.
Let me just add one other piece to it, because my guess is that most of you have heard about the ACEs study, and certainly it emphasized risk, and that the more adverse events, it raises the risk around, you name the problem and it raises the risk around the problem. But what's also interesting in that study is the number of people who had really terrible things happen to them, and yet were able to not experience some of the most negative aspects associated with having highly stressful, overwhelming experiences, particularly in childhood. So we should that's like an extremely important finding, and trying to understand what that's all about is really part of what the whole discussion of resilience. So ACEs revealed both risk as well as that there is considerable resilience out in the population as well.
Yeah. And this is just a quote from Robert Anda, who was one of the co-investigators on the ACEs study. What's predictable is preventable. In other words, if we know the cause of someone's problem is rooted in trauma, and we know that there are ways to build resilience through trauma, then we can prevent either mental health problems from occurring, but also from exacerbating or getting worse, or helping people recover. So just a quick word on the history. So the history of the concept of resilience goes back to work in the 1970s, and researchers were interested in a very vulnerable population, that is, young children growing up with parents who had schizophrenia. And what those researchers found or noticed there were children, just as Tony was talking about in the cases of ACEs study, that there were children who were extremely resilient, were very able to sort of overcome the difficulties associated with growing up in a family where the parent has schizophrenia. And so they were interested in what are some of the characteristics of those young children, what helped them to overcome and work through their trauma. And there's a long history there, but initially, when they looked at some of the individual strengths that these kids had, it was clear. And there were some character strengths. The kids were very confident. Some of them had charisma. They had many sort of personality traits that helped them, too. But as they sort of followed those kids, one of the things that they found was that it wasn't just individual traits, that there were other supports out there that the young people had that helped them to manage and cope with and overcome the adversity of growing up in a family with schizophrenia. As time has developed, the concept has gone through a lot of, and we'll talk a little bit about it in a minute, has evolved in many ways. And more recently, it's been picked up by mental health researchers who are interested in the social determinants of health, interested in understanding the social context of health and mental health problems, and what impacts, how the environment impacts health and mental health problems and development. So that's sort of where we are right now. A very brief definition of resilience, and there are many. One of the things that we want to be clear about here is that there's still controversies. One of the things that we feel strongly about, and one sort of camp that we fall in is looking at resilience as a process that reflects positive adjustment despite significant risk or adversity. So a couple of things I want to say about that is, again, that it's very complex. Our presentation is going to focus a lot on this definition that looks at it more as a process, but there are aspects of it and there are folks out there who believe that resilience is actually a trait. It's something that sort of you're born with, that develops, and falls within the individual. And again, there are the camps that look at it, again, more as a process and something it lies both in the individual but in the supports around the individual. A few things about this, looking at it as a process. First, that it's context-based, it's situational. So resilience can be different depending on the situation. For example, a child growing up with in a family where the parents are depressed or if there's maternal depression, resilience would look like a positive adaptation or no mental health problems in the context of growing up in maternal mental health. A young person growing up in a crime-ridden area, an area that has a lot of community violence, what resilience might look like is surviving. Or it might look like pro-social behavior in a community that's marked by community violence. It can be domain-specific. So what we know, for example, that people with PTSD, for example, some may be the silent sufferers. They may be able to function perfectly well in their educational system or in their workplace, but have extreme difficulties with social relationships. So it's domain-specific. Someone might be educationally or vocationally resilient, but have difficulties with social relationships. And then, of course, it fluctuates over time. And this is one of the findings from the work that was done early on, that it fluctuates over time. Some people may show resilience at one point in their lives, and sometimes the stress response system can be overwhelmed, and people may not show resilience in different points in their life. So there's a developmental component to it as well. So that, and therein lies the complexity of this notion of resilience. What it is not, and we put a question mark in here, is because, as we said, there's some controversy still in this field. There are people who wonder whether resilience is the same as just general competence, or looking sort of at things more psychodynamically, ego resiliency, or even grit. Another concept that is out there is hardiness. And so one of the things, again, in this controversy between is it an individual trait or is it more of a process, these are some of those individual traits that may be associated with resilience, but from our point of view, not necessarily resilience solely. Okay. And just to be clear, for example, with the issue of competence, one of the reasons why resilience researchers who see this process don't see it as competence is because competence does not necessarily entail exposure to adversity. You can be competent without being exposed to adversity. You don't necessarily need adversity to be competent. Now, in general, for people, sometimes people develop competence out of dealing with stressors. So, for example, a young person who gets anxious about a test that's coming up will certainly feel stress and will develop greater competence if they push themselves to do better in that test, but we might not necessarily call that resilience. And therein lies some of the controversies. Some people would call that resilience.
Well, Jim, the way I feel about this is that when you think of like grit or hardiness, it kind of means if you can kind of, just sort of almost insulate yourself, that you're very tough. It's maybe very much of an American idea, that you can handle stuff that comes by you, you can kind of dig in your heels and flex your muscles and manage whatever it is that comes your way, that you're tough-skinned, that kind of idea. And I have to say, that just never really appealed to me very much, to think of resilience, as that. And yet, out there, they're doing research on what they call grit or hardiness. And I think in some ways, one of the points, and we're in the camp with the folks who kind of view resilience not as just this ability to toughen yourself up against difficult circumstances in life, but really as this kind of transactional process that involves the context that you're in, the environment, the resources, the supports, and that it's not a fixed, trait of individuals. However, if you look at the issue of competence, I would say that if our mental health system, if our educational system, if all the really the entities that we have in our community were designed to really build on the strengths and the skills of folks and to enhance that would be a very positive thing. But again, I think we're seeing resilience in a much broader context than just toughness.
Right. And so, so when someone has demonstrated resilience, there's a few different ways. One is that they may be exposed to extremely adverse events and show no signs of unhealthy coping or response, no disorder, no major problems to potentially traumatizing events. And that's where, again, going back to, as we were saying, as an individual trait, we might call that resiliency, someone who has grit or hardiness or many of these other individual traits that might, as Tony was saying, insulate them from reacting negatively to potentially traumatizing events. But then there's two other ways, and for mental health providers, this is where we're more focused on, obviously. It's thinking about resilience as recovery, improving coping responses after unhealthy coping in response to potentially traumatizing events. So some people will be affected by potentially traumatizing events, and of course our job is to help people recover to some basic level of coping and adaptation in the face of trauma. And then actually, for some of us as well, looking even beyond that to prosperity, helping people find joy and expand their lives and find meaning and make meaning out of their experiences and actually grow from it. So in many ways, these are some sort of outcomes related to resilience. And again, going back to looking at the interaction of the individual strengths that people have, or what we would call assets, the role of significant others or resources in the person's lives, and then the importance of systems and culture as additional resources in the person's lives. This is our sort of view of how resilience develops. Resilience doesn't fall on the individual, nor on the significant others, nor on the systems and culture, but in all those areas, that we can see resilience in all those areas, or all of those areas contributing to resilience. Individual strengths contribute to resilience, significant others can contribute to resilience, systems and culture can contribute to resilience.
You know, as you say that, it just came to mind for me, Jim, is that you can have risk, right? There's risk in any of these areas, right, of the individual strengths, right? So you need to know that, right? What are both the strengths as well as risk areas for the individual against significant others? Are they positive sources of support, or others can actually be a source of distress? And then looking at the outside culture from all our institutions, right, including the ones that are represented by the audience here of behavioral health programs or other support programs for individuals who are struggling with mental health or substance use sorts of, sort of difficulties. So I think in a way it gives us this kind of complex picture of understanding both protective factors and risk factors in these three domains.
Right.
And, as a clinician, I spent working with adults for many, many years with serious mental illness. I must tell you, I wasn't really thinking in these terms. It was kind of like stuck on, the individual symptoms. Do they meet criteria for a certain diagnosis? Then you got to have some treatment, which is usually meds, and some psychosocial kinds of supports. But it certainly didn't. I must tell you, I just wasn't in that frame of mind, nor was there anything in the documentation process and the expectations for me to take a very strong look, at those personal assets and some of the challenges. Yes, we were filled, I would say 90% of our documentation was filled with what's going wrong, right? Not what's strong, but what's going wrong. And then not looking so deeply at the social environment, nor the other contextual entities in a community, everywhere from housing to, or if they're in a work environment, or what it was like in a neighborhood. It just didn't capture our attention in the same way that the individual difficulties kind of attracted our attention and then became the focus of so much work. So I think there's implications for taking a much broader perspective on this.
Right. So going back to our three circles, right? So these are just listing out some of the individual characteristics. Again, in resilience terms, what we might call assets that individuals have: temperament, personality traits. Again, going back to some of those things we previously noted: ego resiliency, competence, grit, intelligence. These are many individual characteristics that someone can have that can help them overcome adversity.
Right.
In addition to that, the role of significant others, resources, right? Principal among this, and there's a ton of research on this, of course, is the role of family and parenting, attachment. to key figures and significant figures, and obviously principally parents and caregivers. And then attachment, early attachment, but then also later on, the importance of the parenting environment and the role of parents and caregivers in monitoring and supervising young people and supporting them. And then other significant people, peers, of course, and developmentally, we know that as peers move into adolescence, or as young people move into adolescence, peers become more important. And then the importance of other significant people, mentors, extended families, and extended family members, and other social supports that may be out there that can be found to marshal support for the individual. And then in terms of system supports, and this was something that Tony was referring to, again, quality systems, quality schools, or at the very least we can understand the role of schools in contributing to resilience, sometimes also in not contributing to resilience. So schools engaging services, engaging programs, whether you're providing case management services or mental health services, quality care, the use of evidence-based practices, and then something that we often talk about here, the trauma-informed systems, systems that can promote safety, connections, emotion regulation, all of which are associated with resilience.
You know, I would actually, you know, looking at that list, what's come to mind for me is you can have other cultural entities as well, which is the way in which criminal justice takes place, right? Or the safety net types of like services, the resources that are, I'm talking about financial resources, housing resources. All of these things play an incredible role. Even the toughest temperamental child, right, or adult, whether it's through temperament or having confidence about the future, and these very positive things that keep you moving forward, even in adversity, they can be overwhelmed by just being in settings where there's just continual sources of stress and anxiety. You know, human beings are vulnerable to this. I mean, the neurobiology that, you know, Jim is going to be speaking a little bit more about, you know, we do have a human stress response, and it can get overwhelmed. And when it gets overwhelmed, you know, even, quote, the most resourceful and resilient individuals can begin to show some really negative signs of cumulative stress over time. So it is important to kind of view that you don't have this category of there's the resilient people and then there's the non-resilient people. And it's not the way it really works. Right. And I think it's important to recognize that as well. Okay.
And maybe less relevant, but we want to mention it here, maybe less relevant for our purposes, but it is important. The larger cultural context, right? So the importance of things like religion and spirituality that can contribute to resilience. Even ethnic and racial identity development, the connection that someone has to their culture. And this is just an example. Resilience researchers working specifically with African American males in poverty-impacted communities, doing interviews with them, qualitative study, identified these 5 factors as important towards resilience that these young men sort of identified, and that's perseverance and refusing to quit despite challenges, a commitment to learning and growing from hardship, using reflection and refocusing, reflection on the past and refocusing towards the future to overcome adversity, creating a positive and supportive environment, finding those social supports. Again, all of these things that are critical aspects of resilience, drawing on religion and spiritual strength.
Can I just say something about that last one around, you know, these religious? You know, it's interesting how so many studies have demonstrated that individuals who are part of a religious community and have a deep spiritual belief in both in prayer and in, you know, the sense that one is not alone and that one can get guidance from a spiritual being. As it turns out, that seems to really be a very important insulator and helping people to kind of get through, particularly getting through very difficult times. I mean, Jim, does that make sense to you as well?
Yes, yes. And clearly that's what the research shows. The research shows that religion and spirituality, those are larger issues that help people make meaning of their lives. And meaning making, again, as an important component of resilience is critical.
Well, this is how I screwed up in the work that I was doing back in the 80s. I didn't ask about this stuff. I mean, we had a face sheet that you had to ask with the person's religious affiliation. But the idea of exploring the degree to which a person, you know, what their particular religious belief system was or a community that they were part of, and the degree to which that was a source of comfort and reassurance, especially during difficult times. Again, I kind of look back and really say, you know, that's certainly not something that I was doing, and I don't think my colleagues were really addressing this, but the research today on resilience is sort of indicating, like, you ought to have that in your mind, that that's not a, that's a significant area that helps individuals manage difficulties. And by ignoring it, you may be ignoring a great source of enhanced resilience for an individual.
Right.
Okay.
And then this is just very quickly, because I thought this was amazing, again, at the macro level, even more broadly thinking about resilience. This is some work that was done with First Nations communities in Canada. And what they found was in tribes, in bands of First Nations communities around Canada, they surveyed those communities and sort of looked at factors that were associated with those communities, things like their ability to self-govern, land claims, and how much they own the land, and the education services and health service, the quality of those services, the cultural facilities and connections to cultural programs, the responsiveness of police and fire departments, and then the use of native language. And what they found was amazing. When you think about it, these factors, what they found is that the number of these characteristics of the community rose. The suicide rate decreased. So when they found no indicators of any of these things in the community, the suicide rate was 137.5 for every 100,000 members of the community. As those rose, as indicators of those factors grew to 6, the suicide rate dropped to 0. Just another sense of how resilience works at this larger macro community level. So with that, we're going to switch from the macro back down to the micro. We're going to talk a little bit about the neurobiology of resilience very quickly. So this is just a study that was done by Sinha, and it's looking at the resilient coping brain and the risky coping brain. And let me say very quickly what they did in this study. What they did was they took people and exposed them to recurring stressful events or stressful images, things like images of terror, mutilation, disgusting images, with images as well that were neutral, and they kind of balanced them off. They showed them to folks and then looked at their MRIs of their brains, functional MRIs of their brains. And then afterwards, they asked people, they took a little history about their coping strategies, how they coped with stressful events in their lives. And what you're seeing here is the brain scans of people who were resilient coping. So people who used their imagination, who were able to think and use their executive function. In many ways, when they were exposed to those stressful events, what you see with resilient copers is that there's a lot of activity in the prefrontal cortex, that area of executive functioning, the decision-making unit of the brain. And there's a lot of activity in that area. When you look at people who are risky copers, so these are folks who cope through alcohol, through drug use, through avoidance, in many ways show risky coping strategies. You can see there's no activity in the prefrontal cortex of the brain. What this tells us is that when we are exposed to stress and strain, for those who are considered resilient, there's a lot of activity going on. They're thinking through, and I'm going to talk a little bit more about how that develops in a minute. For those who engage in risky coping strategies, again, their ability to think and their ability to process what's happening to them under stressful situations is compromised. So very quickly, how does that happen? Actually, we can talk a little bit about how that happens in broad ways. So what we know about the neurobiology of resilience is that there are genetic factors, epigenetic factors, and neurochemicals that all play a role in resilience. I'm going to go through those very quickly. First off, just a quick overview of genetics, okay? Just a reminder, okay, the body is full of cells, millions and millions of cells. And on each of those cells, in the nucleus of each of those cells are chromosomes. And on those chromosomes, there is DNA. That DNA is carried in every cell of the body, and that DNA is set. That DNA is the script for a person's life. And what we know about DNA is that it does not change. However, they can be activated or disactivated or turned on or off. And very quickly, I won't go into the details on this, but there's two processes that we know that contribute to turning on and off certain genes, and that is the process of methylation and acetylation. I won't go into depth, but science is telling us a lot more about how this happens, all right? And so from genetics, the reason why there's a big and growing field called epigenetics is because epigenetics, that process of methylation and acetylation I just referred to, is what's going on around the genes. Again, to repeat, the genes and the DNA is set. It does not change. But what happens around them, like this process of methylation and acetylation, can either turn genes on or off. All right? One of the best analogies I've seen about this is to think about genetics as a movie. And the movie is the entire product, but the movie is made up of the script. So if you think about the DNA is the script. The script doesn't change. However, what does change, what can change as a result of, the DNA is the script. The actors you might think of as the cells, right? The DNA tells the actors what to do. And then lastly, the concept of epigenetics is like the idea of a director. A director is the one who decides what parts of the script they're going to focus on, what parts of the script they might include or take out. I think it's a great way of thinking and understanding how epigenetics works. But what we also know about epigenetics more and more is that epigenetics, as I've already said, controls genes. It's unique to every individual, so every individual has a unique way of, obviously, of coping. So a movie will look very different if the director is Spike Lee than if the director is Steven Spielberg or if the director is Quentin Tarantino. It will look very different. It'll still be a good movie, but it'll look very different. And then the other thing is it's plastic. What's critically important is in the study of epigenetic genes and gene expression is plastic. It can be changed, as I said, turned on or off. And lastly, epigenetics is everywhere. So as we talk about gene expression, it's everywhere. We're talking about in the cells how this process might change and turn genes on and off, but also in the environment, there are things that affect that process of methylation and acetylation, and these are some of the epigenetic factors. Things like exposure to stress, environmental toxins, the prenatal environment, diet, exercise, the developmental and critical periods, aging, viruses, and infection. These are all the things that can affect the expression of those genes through this epigenetic process.
Well, you know, as listening to this, my takeaways, right, is a couple of things. One is, if you were to look at how people cope, if a person, because I'm thinking as a clinician, right, in providing services, and I'm saying to myself, okay, there are individuals who engage in effortful coping, problem-solving kind of focused coping, and they have a lot of activity in their frontal lobe because perhaps problem solvers, people who begin to make informed decisions, gather information, have ways of addressing whatever stressful experiencing that they're encountering, there's like your frontal lobe is in charge. Whereas other individuals who have gotten away from effortful coping and rely on whether it's alcohol or external types of coping responses, that it's reflected in their brain, right? And that over time, people can begin to almost deactivate the frontal lobes and instead of activating them. And I'm thinking as like a clinician, how do I increase that? How do I ensure that I engage individuals in being able to really begin to cope in a much more problem-focused sort of way? So that's one of the messages to me, which I think is really important. The second thing about the genetics and all, it's really interesting, especially the epigenetics. I never would think, right, that the offspring of someone that I was like working with, that it was whatever the genes were passed on, that's like pretty much it. But I think the epigenetics is telling us that the expression of genes is very different than just the genes or the DNA itself, and that there are chemicals that turn things on and off, and those are affected, as Jim, at this slide here, if you had a lot of stress, it's affecting those chemicals that can turn things on and off. or toxins, or the prenatal environment, or people's lifestyle, right, from diet and exercise, aging, virus. So this has become very, very, I mean, it's very exciting kind of work that's taking place. And in a way, when we benefit the patients we're working with, it may not be clear to us, but we may in fact be also affecting the next generation, which I think is like a very exciting and very important part of anyone who's involved in public mental health.
And Tony's not underestimating that. That's what epigenetics means. We can not only prevent illnesses from occurring in the first place, we can change them. And actually we can change it over generations, because these processes can be passed down intergenerationally. This is just a quick picture just to make the point about epigenetics and the impact of epigenetics, but also on stress. On the left-hand side, you see a twin. That's a twin pair. Twins are, in terms of their genetics, exact copies of each other. They have the exact same genetic code. On the left-hand side, you see a woman who is a non-smoker, and on the right-hand side is her sister, who is a smoker. According to genetics, historically, they should look exactly alike. But what you see is the impact of the environment and smoking. And then on the right-hand side, the graph you see there, just to bring it back into ACEs, is the other thing that we know is that with ACEs, right, as there's an increase in the number of ACEs people are exposed to, there's almost 250% increase with people who have 6 ACEs who are exposed to 6 adverse childhood events in their lives, 250% increase in smoking, right? So we can see how these things develop and co-occur. One of the things that Tony was also mentioning is the importance of learning. Very quickly, so when we talk about genetics and epigenetics, these are, in many ways, there's many other systems involved and many other structures of the brain that are involved with behavior and expression. But these are just some of the neurochemicals. So when we're talking about turning genes on and off and the expression of certain genes, in many ways what you're talking about is the interaction of all of these neurochemicals. I'm not going to go into depth on all of these. We can talk further about this, but just to give you an example, we know, for example, in the HPA axis, the hypothalamic pituitary adrenal axis, the production of cortisol is high, right? What we also know is that with cortisol is protective, it helps the individual, it prepares the individual, but when the system is overwhelmed by stress and there's too much stress, cortisol can actually attack the immune system and create problems. So some people under extreme stress produce too much cortisol, again, the environment impacting the cortisol production and leading to, in many cases, difficult problems. In the sympathetic nervous system, we have norepinephrine, neuropeptide Y, and galanin. These are also hormones that act as neurotransmitters. Again, we won't go into depth, but what we know is also that there's this relative relationship or ratio of these neurochemicals that impact behavior and gene expression. So just a very quick example, norepinephrine, that's something that is triggered in the fight or flight response and allows people to pay greater attention, believe it or not. It allows people to attend to the threat, right? But what we know is that what's needed in stressful situations is not only that attention to the threat, but also a calming factor. Neuropeptide Y in the same system has to be in ratio to norepinephrine in order to keep the system in balance, because if you're just focused on the threat and not thinking about how to deal with it and how to calm yourself down and what to do about it, you're in danger. Remember the brain scan I showed earlier. Under stressful conditions, there's some thinking going on. Neuropeptide Y allows you to calm down enough to think. And then we have other neurotransmitters like dopamine and serotonin. The other thing I won't go into depth on all of these, but just to understand that all of those neurochemicals are impacted by the environment. And just to give you some sense of some of these, you know, NPI, that neuropeptide Y, we believe can be affected by certain diets. So can galanin, another neurochemical in the sympathetic nervous system. We know, for example, that serotonin, believe it or not believe it or not, many of you may already know, serotonin can respond or can increase. Serotonin helps to deal with anxiety and balance people's moods. And it is affected by sunlight. It's affected by massage, exercise, and actually remembering happy events. Serotonin levels increase when you're remembering happy events. we know that that could be taught. We know that people can be helped in terms of using remembering happy events when they're in stress. So these are just some examples of how the neurobiological system can be changed, addressed, and adapted for the individuals.
You know, it's interesting. I've actually, there are some neurophysiologists who look at our field, right, psychology and social work and behavioral health, and they say, well, how come when you're seeing a patient, you don't take their blood pressure or their pulse or perhaps even a cortisol level? How come that's not part of your work, right? So it sounded bizarre to me, but they were making the case that when you're working with someone who is dealing with emotional, mental health difficulties or addictions and things like that, that you have like no idea what their particular arousal state is, right? So one is blood pressure or pulse, give you a sense of what that person's kind of like almost baseline of arousal, right? And if a person is like too high, it actually interferes with like learning, right? If it's too low, it interferes with learning. And the other issue around like cortisol, which we kind of know that it's really elevated when people, particularly for individuals under a chronic kind of like stress. I know it sounded kind of odd to me, but then when you think about it a little bit more closely, that's because we've separated behavioral health from just general, medical or general health care. Because it's been separated for so long, we tend not to think in these terms, right, of understanding the physiology of individuals. And then the other piece that, Jim, that you mentioned is, talking therapy can certainly do a lot, and it can certainly affect people's serotonin levels. One of the things you mentioned is when people are able to engage in pleasant sort of ideas or positive possibilities or individual people, places, and things that are associated with a positive experience, that can affect the neurochemistry. But also, we often forget, at least I have forgotten about the role of like diet, the role of exercise, the role of meditation, the role of many of these physiologically based physical activities that people engage in to try to influence the biology or to give the person the best shot. I think that that's huge in the implications for the work that we do, and this area begins to sort of get us to think about how we incorporate that in the work that that we do. Right. So I think that's my takeaway really from this whole area of the neurophysiology piece.
Right. And so a quick word on some of the basic research on resilience. In other words, looking at the resilience and how it's associated with other outcomes and other kinds of things. So resilience has been shown to decrease self-reported fatigue in people who've gone through, who've had traumatic brain injuries. It's associated with healthy lifestyle and wellness. As we already said before, healthy eating, exercise, decreases in tobacco use, increases in fatigue. It's also associated with decreases in depression and anxiety, overall life satisfaction, and religiosity. So there's a relationship between these things. We don't always know what direction that relationship is, but we know these things are related to each other. And then outcomes, so there's been some studies that have been done of people who've been developing interventions that are specifically focused on trying to build resilience, and these are some of the outcomes associated with them. Self-efficacy and personal functioning for people with severe mental illness, decreased adolescent substance abuse, PTSD symptoms, a decrease in PTSD symptoms, and positive emotional health. So these are many of the things. Also working with people with type 2 diabetes with their self-management and psychological and physiological wellness. One of the things that I want to focus on is that that the interesting thing, going back to that first study looking at people with severe mental illness, this is people with co-occurring, comorbid Axis 1 and Axis 2 disorders, okay? One of the things that they found was that actually, now this might sound a little counterintuitive, but what they found was that resilience factors were independent of symptomatology, that people still may have been symptomatic but still reported resilience. We still got to think about that, but what I want to point out is resilience is not the same thing as having or not having symptoms. And then some of the components of those studies that I was just referring to, many of them did simple psychoeducation on resilience. So one of the things and one of the reasons why it's important to understand resilience is because you can also teach it. You can talk to people about things that they can do to increase resilience. If you have a resilience focus, we do psychoeducation on things like trauma and depression and anxiety and what causes those. We should also be thinking about doing psychoeducation on resilience. How does it form? How does it build? How do you create it, and how do you develop it? So that's one thing. But then these are some of the other things, components of some of these other interventions that we're going to see later as components that are critical to building resilience. Finding positive meaning in the context of disease. Reframing someone's disease or difficulties in a positive way. Of course, emotional regulation and social connectedness. We're going to talk about that, a lot about that in a minute. And then some work around basic CBT components, things like teaching psychoeducation, cognitive restructuring, relaxation techniques, but with a focus on, again, emotion regulation and social connectedness. So in work with people with tic disorders, helping them talk to others about their tics, helping them to respond to bullies and deal with the social environment, and then not limiting activities because of the tics. So continuing to push for that social connectedness that we're going to see is a big theme. And then research on resilience in children. So these are a few of the outcomes. Therapeutic foster care, going back to this relationship between intervention and biology. One of the things, a study done in therapeutic foster care was that, and very quickly in therapeutic foster care, this is putting kids who are at high risk, kids who have severe problems, who are in the foster care system, putting them in foster care homes where the parents and caregivers are trained in good discipline strategies, where the young people are given social skills and provided supports connected to other areas. It's a very multidimensional approach, but one of the things that they found in that is that the results of that showed that the caregivers, and they were tracking people's cortisol levels, the caregivers had regulation of their cortisol systems, as well as the young people in their care who showed better regulation of their cortisol levels as a result of the intervention that they were involved in. So again, we're beginning to see that interventions can have these talk therapies or psychosocial therapies that we use actually does have an effect on the neurobiology of individuals. And then in addition to that, other research has shown that social and emotional learning increases resilience. Tony was mentioning this earlier, right? The schools, social and emotional learning programs in schools that help teach kids social skills, how to get together, problem solving, all those kinds of things are really critical in building resilience. And then treating maternal mental health, that improves parenting. So these are just examples of how there's research being done on resilience and interventions developed focused on building resilience that are showing some positive effects. So building resilience, we're going to switch now in what you can do. With the time that we have remaining, we want to sort of focus on, you know, what programs and individual clinicians or individual providers can do. So look, there's one thing. We already talked about the definition of positive adaptation to risk. So if that's your definition, right, there's a few ways of building resilience. One, you can build on strengths. You can identify those individual assets that people have or the resources that they have around them and build on those. Right? So a simple example of that is some of the things that we've talked about. Many of our treatment focuses on building individual abilities to cope, using people's intelligence, whatever that may be. You can also increase protective factors and focus on increasing protective factors. So another example of that is the study that I just talked about with treatment foster care, right? Increase the individual children's abilities to develop social skills, increase their caregivers' ability to provide support and discipline and provide proper limits to their kids. So that's increasing the protective factors. And then reducing exposure to risk. Many who work maybe in domestic violence and helping people deal with safety and create safety in the context of risk is an example of reducing the exposure to risk. And then there's all kinds of prevention methods, primary, secondary, and tertiary, to avoid making problems get worse. Oops, sorry.
Okay, so at this point we've thrown a lot at you, right? we wanted to, this idea of what do we mean by resilience, and it isn't a simple answer to it. Taking a look at the, the neurobiology associated, with resilience, why resilience might be an important area for us to take a look at. So this, Jim and I were thinking of, so what does this all mean for the way that we do our work? And I think of it, and Jim and I both who've, been clinicians, thinking about, so, now that I know this stuff, so does it change one bit of what I do? And so when thinking about trauma and resilience, the image that comes to mind is really of a bifocal. There is a lot of talk about, looking at things through the lens of trauma, but we think it's really a bifocal lens, where it's also looking at through the lens of resilience, and really involving that we need to assess the severity and chronicity of the person's risk exposure to, like, terrible things that have happened to them. And sometimes it's not just events, but like the conditions in which people live day to day. There's kind of like chronic demand upon a person's stress management resources. The other is to do an assessment of the comprehensive resiliency promoting personal and environmental factors. And if we were to practice that way, would it be any different than the way we currently practice? So let's just take a look at this piece. So the practical and immediate clinical focus that aligns with building resilience. The first thing is maintaining a very comprehensive and continual focus on personal strengths. An opportunity to utilize the people, places, and things in the person's life that are reliable and helpful resources. Unlike the way I would typically have done assessments back in the day, where I was zeroing in really on the individual's symptomatology and their difficulties, rather than being as obsessed with difficulties as I would, really trying to be obsessed with the strengths as much as I was oriented towards understanding difficulties. Understandably so. People come to us because they're having problems, and it makes perfect sense to really focus on that. But the resiliency lens says, you're really missing out on what can, in fact, be the key factors to help that person kind of address whatever struggles that they have. And so, and then the idea of my diagnosis needs to go beyond, looking at criteria for symptomatology aligned with DSM-5 and looking for those external potential resources, people, places, activities, things in that person's life that are both reliable and can be helpful resources. And the second point, which I think is maybe critical, is assisting clients to identify, engage, and develop strong social bonds. All the literature, there hasn't been, in fact, I don't think there's one literature or one part of literature that says, having social connectedness is not important. It is absolutely true. In fact, I don't think we need to study social support anymore. I mean, there's tons of studies. They're going to go on in the future. But they're one of those areas where I think the study should actually end with, okay, no more studies are needed. We pretty much got this. And I think that that's absolutely true. So in working with clients, asking ourselves the question, who is in this person's social network? Who is in the social network that can be a support in this person's treatment, and recovery? And that's a very serious decision point and part of just good clinical practice. Sorry to say that as much as we were very oriented towards involving family members when I was working with people with serious mental illness, that was very, very strongly emphasized, and we had a tremendous effort around engaging family members. In my contact with many agencies across really the country, there's much, much, much less of that going on, much less of exploring a person's social network and maybe mobilizing or engaging or involving a member of a person's social network in care. That in and of itself is a very powerful resiliency supporting type of intervention. And so it's a bit upsetting that has really declined significantly, like, over the years. Okay, so let me go on to the next point. So what is it that we all need to know? One, that we can strengthen a person's resilience. I think we want to make that point, that it is not traits. that are part of the individual's makeup and generally not malleable. And what that really means is the ability to more effectively manage the impact of highly stressful events in the past, in the present if people are continuing to experience these adversities, but also in the future. And I think resiliency has a future perspective. It's not just about relieving an individual, which is so important, of course, of any suffering associated with stressful experiences in life, whether they're PTSD-related or may not meet that criteria, but still it's impacting that person's life, both in terms of distress or functioning. But it's like, can we build a capacity for individuals to deal with future stuff? So if you have that brain that, with Jim mentioned, that somehow is like risky sort of way of coping, can we help individuals to activate that part of their brain that is problem-solving oriented, rather than the avoidance or the use of external stuff in order to kind of manage day to day. So I think that those are important issues, and as you think about it, you can ask yourself whether or not that's something that would make practical sense for the work that you do. So also in the context of higher exposure to adversity, the environmental factors may actually be more important than the individual factors. Now, we're very much tethered to our offices oftentimes, depending on your role. Others are able to kind of, get out there. But oftentimes we find ourselves having to kind of deal with the individual, him or herself, rather than having a way of engaging potential contextual factors in that person's life, whether it's family or it's where they live or the people that they hang out with and those sorts of things. But the more difficulty, and if all we're working with is that individual, in a way, it really may not achieve the kinds of positive outcomes that we would want. So even maladaptive patterns of coping may be signs of resilience. Now, what does that really mean? Sometimes individuals choose a coping response. They really haven't got much choice. If you're young and you are in a very difficult situation, you don't have much power, you select and you find an approach to kind of get you through the day or to get you through this difficult thing. And in the short run, it makes perfect sense, right? It's like the idea of like taking a drink in order to get through some difficult time. But then in the long run, that can become your sort of approach to the way you cope with not just that particular event, but other stressful events in your life. And now all of a sudden, you become that brain that's the risky coping brain rather than the problem-oriented brain. But it's also not to judge people on the selection of coping responses. I think no matter what the coping response is, one's attitude could be like, look, this is what made most sense to you at this point in your life, given the situations that you were in and given what you knew that was available for you to do. And I do think that that's an important issue, because we don't want to come across like being judgmental about the kinds of coping responses that individuals have selected. It's built into us to deal with stressful experiences. Sometimes we're left with just avoiding and running away. Sometimes we're left with developing aggressive tendencies to kind of like fight against it. Sometimes we freeze in place, right? And the idea of developing resilience is to expand that person's repertoire of coping. Okay, so let's go to the next. Assessing. So, of course, assessing risk is something that you guys know about, but I want to kind of speak about, again, like, there's the trauma and there's the resilience, and these go hand in hand. The age of initial exposure and duration of adversity, the severity and duration of adverse events and conditions, the number of events. The ACE studies kind of told us, sometimes when people are just hit over the head with one kind of difficulty, they can manage it, maybe another kind of situation you have to deal with. But if you have multiple adverse kind of experiences and events, after a while it exhausts your capacity and raises the risk for all negative things. And we learned that very, very much from the ACEs work. The current challenges and difficulties associated, so, what does it really mean that you're, in terms of your life, both in terms of your distress or your functioning? And, I think it's important to also take a look at the cultural, familiar, religious beliefs and values. That the idea of like trauma, I mean, we may feel comfortable with it as professionals, but not all cultures may even have the same term for what we're talking about as trauma and what trauma means. So what is an adverse, what's a bad thing happening? What does that really mean? Is that something universal, that every culture and family kind of sees bad stuff in the same way? And then why do bad things happen to people? Sometimes there's the issues around the role of sin and punishment and forgiveness. And how are people expected to deal with these things? In some regards, you rely on prayer or religion, on God, or you have to have a penance. There's the continuum of cultural values and beliefs that needs to be looked at. Also, the idea that you tell strangers your business, right? Especially these very, very intimate and personal experiences. The idea of keeping or disclosing secrets, and then gender-related expectations. With boys and girls and men and women. Ought to be doing in terms of the various biases around that. So that's part of assessing risk. I did want to share with you, a lot of the studies that Jim mentioned around resilience, people would develop a scale called the resiliency scale, and they'd give it to a lot of people, and then they would say, is there any relationship between those who scored high on resilience and various outcomes, and versus those who scored low on resilience? So very few of the studies have really been designed to try to enhance resilience. It's just not out there, right? I mean, I've gone through this literature, and there aren't. And you probably haven't heard of resiliency building programs. In fact, I've been working on one over the past 4 years myself. I do think that we need to get away from the notion of a treatment for a problem and the positive, sort of like illness versus wellness, right, and trauma versus resilience. And I think there's increasingly a need for that. But I must tell you, the field hasn't, at this point, really developed a robust, approaches to how do we build resilience? What do we know about it? And are those factors something we can do something about? So I just wanted to share with you some of the major scales that are out there and give you just an example of what, if you come across literature on measuring resilience, these are examples of some of the questions that go into it, okay? So the Connor-Davidson is a very popular one, and they have 4 major factors, right? So one is people who are resilient, right? Meaning that if you score high on this, you tend to be able to manage a whole host of stressful things. You manage your physical health problems better, you have lower rates of depression, anxiety, all that sorts of things. These are all correlational types of studies. So they'll ask questions like, I can handle unpleasant feelings, I tend to bounce back, I can make unpopular, difficult decisions. So if you were taking this scale, you might ask yourself, well, how would I answer this? Can you handle unpleasant sorts of feelings, and do you tend to bounce back? Those would be a factor on flexibility to cope with unexpected events, changes, and challenges. Factor 2 is social and familiar. There's always social and familiar support across every measure of resilience, right? So if you have people who are willing to help you, listen, friends are willing to help, you have close and secure relationships, attachment, that kind of thing. If you answer yes to that, you're in a better position. So if you have clients who have a very limited or very problematic social and family network, that's like really serious. That, or, somehow or other, that ought to get onto those plans, right, as in terms of a service plan, because it's so associated with the likelihood of a person being able to successfully achieve goals and deal with whatever life problems that they have. Another factor was spiritual support. We mentioned this already. So individuals who say sometimes fate or God can help me, things happen for a reason, I can pray when I'm faced with difficult circumstances. You score high on that, you enhance your resilience, right? And so exploring that with individuals, if they want to pursue, connections to religious, communities and all, and it's positive for them, and of course it's never so simple, right? With the motivation behind it, that is associated with it. And then being goal-oriented, right? So if you think of the future, you have some confidence in the future, that's going to help you to deal with adversity. Just a couple of others, a 2-factor resiliency scale for adults, and you can see if you want to learn more about it, you can go to the reference that we have at the bottom. Personal competence is an important one, right? acceptance of self and of life. This notion of acceptance seems to also be part of it, that when bad stuff happens, it's kind of like, look, life has complications, rather than this is the most catastrophic thing that's happened, and I'm the only one, and a person can get into that frame of mind, and it just makes things more difficult. And the last one is there is such a thing called the brief resiliency scale. These guys who put this together, Smith and others, is like, look, after all said and done, this is what we want to know. It's a single, they use this. It's like six questions. I love that kind of stuff, actually. So they just ask you, listen, do you tend to bounce back quickly? Do you have a hard time making it through stressful events? How long does it take you to recover from stress? You know, those sorts of things. So they just have like a single factor. They just call it, it's resilience. And questions we need to answer. So in this whole area of studying and measuring resilience, are there clinical cutoffs of specific dosages or protective factors that mitigate the impact? So, you know, how much of this protective factors do you need to have to prevent psychological behavioral problems? How do different levels of exposure, different contexts, different cultures, and that really is important, especially if you're in New York, where you have people from so many different cultures, and also religious perspectives, right? Or person, or whatever the familial values might be, that's really, you know, an important factor to look at. And in which context, under what conditions are children likely to develop maladaptive coping, you know, as a pathway to resilience? And what is the relationship between high levels of resilience and a child's recovery? So, and you know, others, which resiliency promoting intervention? And that's really the key. I mean, I think the future, to be just quite, I mean, this is my prediction, is, and I hear so many more people talking about, gee, can we look at the other side of trauma? We know a lot about PTSD. We know a lot about treatments for trauma. We know we have a lot of energy into that. You know, there's like literally, you know, there's some research, some directories I've looked at where they just listed all the different group and individual programs. There's like tons of them out there. But they're all designed to somehow eliminate symptomatology in some way, you know, and some of them certainly embedded within that are some resiliency supporting approaches. I'm not saying there aren't, but you can be a little bit more explicit, and I think perhaps in the future we'll be seeing more of resiliency-specific interventions based on what we know. And can we increase a person's social network? Can we focus more on the strengths? Can we look at their coping styles and enhance their coping? Can we look at physiology, meaning the person's diet, the person's exercise, their overall lifestyle? Can we strengthen that? And how do we educate patients that a lot of these things are oriented towards strengthening their capacity to not just deal with what's going on today, but to deal with what may be going on in the future? I'm going to turn this back over to Jim at this point.
And so we wanted to leave you with a few examples of things that you can do. And so we just put this up because in the trauma-informed care we work, oftentimes there's many sort of components or aspects of trauma-informed care. But we wanted to focus on these three areas that we think, if you focus on it, and as you heard Tony talking, as we talked earlier, there's a common theme going on throughout this, that resilience is about building connections, those social supports. And it's also about helping people manage their emotions. And that could be done at the individual level or through the supports that they have. And then especially with regards to trauma-informed care is having a safe environment in which to do that. So we wanted to go through a few things that people can do. First, individually creating safety. You know, of course, in the work that you do with your clients individually, creating a safe place for them to come and talk. But sometimes it's important to be intentional about how you do that. Thinking about sort of just simply discussing safety and how safe they feel, taking SUDS ratings of how safe they feel, either with you or with specific content that they're talking about in therapy, but also creating a safe enough place, that thinking about safe places. Remember earlier when I talked about serotonin levels and how people thinking about happy thoughts, I know we sometimes almost joke about that. It almost becomes so commonplace, but in some ways there is a biological basis for trying to promote that. So getting people to create a safe place and having a place where they can go, but really working at it. That's one thing. And then repeated checks on safety. That always has to be paramount, especially in the context of working with trauma and people who've been exposed to adversity. But also there's things that the provider system can do, like changing the environment, addressing the waiting areas, staff training on being sort of pleasant and respectful with all of their clients, addressing privacy and confidentiality, surveying people on what makes them feel safe, surveying clients in your program. That's an example of how the service system can become resilience-informed. So likewise, connections, helping people make connections. Again, there's a lot of work out there that's been done on motivational interviewing and how to engage people and how motivational interviewing can increase or help to contribute to building rapport in a relationship. In psychodynamic work, processing transference, right? Talking about your relationship and how your client views you is critically important. In DBT, dialectical behavior therapy, we talk about chain analysis as a way of helping people to cope with stressful events, especially interpersonal problems that come up. And then interpersonal psychotherapy is a form of psychotherapy that focuses almost exclusively on helping people resolve interpersonal role disputes and interpersonal problems. Our point is that there's a lot of stuff that's already out there that people can use and try to implement to try to build resilience. We might not necessarily call them resilience building, but they are. And then connections, the providers can do groups. I mean, really the importance of groups for providing opportunities for people to make connections, for providing opportunities for people to develop social skills and develop peer and social support, just providing and offering more groups, and social events, and then play and physical activities. Again, going back to sort of integrating these things so that, as Tony was saying and as we mentioned earlier, exercise and the importance of exercise for people to build resilience. Provider systems can do that. And then in the community, identifying the extent and quality of social networks and helping people explore involvement with social supports in treatment, getting people from the community or having social supports, people who are supportive, be involved in the treatment with the individuals that you're working for, and design the service planning to strengthen connections to those community supports like religious institutions and cultural institutions and other social institutions. And then managing emotions, that last piece, managing emotions at the individual level. Again, working on stress inoculation training, things like breathing and helping people develop those breathing, muscle relaxation exercises, the cognitive coping, that self-talk that people can be taught to help them cope with difficult emotions, and thought stopping, role playing. And then exposure to stressful events and helping them do that, helping them deal with stressful events and manage their emotions through role play. These are all very simple ways that individual clinicians or individual providers can do to help their folks develop resilience. And then in the system, again, adjunctive groups to help managing emotions, things like providing yoga classes or meditation classes or other stress reduction opportunities, or implementing mindfulness-based group interventions. Training staff on psychological first aid, identifying mental health problems, and being able to de-escalate problems that might occur. And then a couple of other things. This is from the APA. APA has identified 12 ways to building resilience. We're not going to go into all of these, but sometimes what we want to do is work on identifying very specific concrete things that people can do to help address these and build resilience at the individual, at the social level. And we wanted to give a couple of examples very quickly of things people can do, things that have already been developed to help people build resilience.
See, I think, to me, let's go back to that slide. See, this to me is like really important. When I ran a day hospital, when I was running a day hospital, I was kind of like thinking we could have actually made this the framework for all the work we did. I mean, we really could have, right? So that somehow or other we're both educating clients about this, but that our programs are all enhancing, making connections, and all the other 12 areas. I think that this is a great blueprint for at least topic areas that need to be addressed.
Right. And we can, and these are just a couple of examples. So for example, one of those factors in building resilience was accepting reality. We know, for example, in DBT therapy, they have some very good ways of teaching people to practice radical acceptance, of working with people to help them accept reality as it is, that pain is a part of life, that the past can't be changed, but the future can. So there's a lot of activities. in acceptance and commitment therapy, the use of metaphors to get people to think differently and accept reality. There are things out there. And then finding meaning, helping people find meaning. When we talk about that, that sounds like an abstract concept. But again, there's been work done on helping people find meaning, and things like asking questions when you have a great sense that life has meaning. What are you doing? What are you engaged in? What are you aware of? There are ways of processing meaning for people.
Right. Yeah, no, it's a really important issue around the meaning, because you can see even when terrible things have happened, you certainly don't want to say that it's meaningful that terrible things happen. It's terrible. It should not happen.
Right.
And no one deserves to have or should experience that kind of thing. But we do see that individuals, when they've experienced like adversity, if they come to an understanding that perhaps this adversity has led them to develop more empathy, the selection of the work that they want to do in their lives, the way that they express some of the challenges with adversity through creative kinds of activities. It's something worth exploring, rather than what's happened has no meaning whatsoever. Nothing has come of it that can be of any value. That leaves people with a terrible sense of that this was just horrific and that's the end of it. People do search for meaning when they've had even difficult experiences in their lives, and that's something we can attend to as well.
And this just kind of summarized many dimensions of resilience. We won't go into depth on this either, but we wanted to give you a sense of when we're talking about resilience. It is multidimensional. So very quickly, before we go to Q&A, as we mentioned, we hope that this is going to be the first of other offerings we're going to do on resilience. We want to get a quick poll, and then we're going to go to Q&A. But a quick poll question. The first one is, with regards to a lot of the stuff that we've talked about today, what topics would you be interested in hearing more about regarding resilience? And what we want you to do is check. You can check more than one. If you can check the top 3 choices that you would have, because if we're going to have other offerings on resilience that we can go in much deeper on some of these areas, we'd like to have your input on that. So please take a minute just to complete this poll question.
Okay, Brianna will let us know when everyone has responded.
We have 5 seconds before the results will be seen on the screen.
Oh, great. Terrific.
Here we go.
Okay, great. Forward to that. Okay, whoa.
More on
interventions. Okay, especially for children and youth, and also for adults. So you know what? I'm with you guys on that one, because that's the area that I'm very interested in as well. There's also interest in organizational resilience, neurobiology, service provider resilience. Actually, there's none of these. I think understanding resilience is the least, and that's probably because this particular webinar focused on that.
Yeah. And again, you know, as I said, we wanted to provide an overview. We hope that in coming webinars we might be able to offer more on specific strategies. And also, if people have recommendations they want to make of folks that they'd like us to bring into these webinars, we'd be happy to hear it. Another very quick poll question: what kinds of activities would you be interested in attending or participating in offered by the CTAC to address the issue of resilience? So, as you know, we do webinars, but we also sometimes do in-person trainings. We have learning communities, consultation with programs, or others. So please take a quick minute to complete this. And then, as I said, we'll transition into Q&A.
And just to recall, the learning community is a more serious engagement where you're really looking to apply what you've learned in the work that you do. And usually extends about at least 5 to 6 months. And it's a more serious commitment, but we are curious to know if anyone is interested in a learning community. That means you really want to take this to a higher serious level.
Okay.
And you know, we really don't have really much time for questions and all, but
more webinars, in-person training.
So people want more webinars.
Some learning community.
Okay, so we have like 55 who said that they might be interested in a learning community, and And other, okay.
More webinars in person. Okay, great.
The webinars in person as well as learning community and consultation. So great. I mean, that's what CTAC wants to know.
Okay.
And again, you know, we have so little time for this, but we're certainly happy if, I don't know if people have been chatting in. Brianna, have people been typing in any questions as we've gone along?
Yeah. Well,
yes, we have a couple of questions that have come in as well as some comments. So I'll pose about 2, given that we have 5 minutes left. So the first question is, what happens when someone has an extensive family and or social network, but those in the network are equally at risk and their support does not help?
Right. Yeah, in that situation, then the focus, and not so unusual situation to be quite frank, in that situation then my focus would be on helping that individual to expand their own social network. It doesn't always have to be you know, blood relatives, close family members, but you're left with the goal of trying to strengthen, broaden, and enhance the quality of social relationships. And if that becomes the focus of treatment, because you've already come to the conclusion that the existing social network, it can maybe be more toxic than helpful. And you have to be really sure about that. You know, you have to really be careful about that one doesn't just throw out the entire social network or family as there's nobody there who can be of any sort of support, right? The other important, so that will be the focus. The other important piece is the identification of who could be a support, and the client has a lot to say about who that is. And at times you may be right that they select someone who, in your estimation, given the description of what the relationship is like, or what that person's particular situation is, that might not be helpful. That's the opportunity to kind of really discuss that. But the really important piece is, whether it's existing or needs to be developed, social connections is not just a nice thing. It is absolutely critical in assisting individuals to deal with every behavioral health challenge that they have.
And the last thing I would add is, I think this, Tony kind of addressed this, but just there are different folks for different kinds of support. In other words, so making a full assessment of those folks who are in a person's life, but they may have different meaning. For example, a person in a person's life, a social support, might be someone that they enjoy hanging out with. There might be another person that they turn to for financial support or mentoring. There may be another person that they turn to for advice and guidance. So really doing an extensive kind of assessment of that social support network is important, and identifying those areas where there may be, as Tony was saying, identifying where identifying new people or different people might be important.
Okay, let's go to the next question.
Sure, let's do one more question. Is resilience affected by psychoactive medication use?
Absolutely. So as I mentioned earlier, so I'll give you a very quick example, as we talked about with all those neurochemicals. So I'm going to give you one example, dopamine, all right? One of the reasons why people who are under stress turn to substances is because many of the substances that are out there, marijuana, cocaine, alcohol, what they do is trigger the body's pleasure and response center. So in many ways, what we know is that that's one of the reasons why people develop those kinds of coping strategies that are negative. Going back to what Tony was saying, understanding that the reason why they do that and the reason why they engage in that is because it's instant pleasure. So absolutely, a lot of times people will be affected by, and it's just another coping strategy that people use to counteract the stress in their lives. They use, obviously, drugs, and it's a simple example, but people self-medicate. But that's how they self-medicate, is by engaging in drugs that increase that dopamine system.
Yeah. And you know, the non-judgmental aspect of it is it makes perfect sense in light of your experience at that point in time, needing something that will help to reduce the anxiety, reduce the stress levels, reduce the depression. It makes perfect sense, right? Human beings just want to sit still and experience the distressing kind of emotions. The problem, of course, is that in the long term, it's the effects are going to be harmful to the individual, and that is I think that's consistent with a lot of perspectives these days on harm reduction, and just recognizing that sometimes even symptoms that we call symptoms may actually be that person's best response to an unmanageable situation, an overwhelming situation that's completely exhausted their own effortful, coping approaches. And so I think that that's the attitude to take. It's very positively oriented. It's, not labeling things as right or wrong or good or bad, but rather, what's going to work for that individual in the long term. And that is, I think, a mindset when looking at resilience. We're out of time, but I just want to thank everybody. We threw a lot at you, which we planned to give you just things to sort of think about. And we hope that this starts like a conversation where we as a field begin to think and talk more about resilience in the same way that we started talking a lot more about wellness enhancing approaches rather than just illness management. So have a wonderful day, and looking forward to seeing you and talking to you on perhaps some of the other resources, from learning communities to webinars and consultation. Stay well, everyone.